Hello, everyone. Happy Friday. My apologies in advance for the audio. I was hoping to be back home, but I'm stuck at my car dealership, crossing the fingers that my car will be okay. I think it's good. But my family and I are taking a little bit of a road trip for this upcoming week, so making sure that everything is as safe as possible. But how could I miss out on this session? Even though you all were expecting Elena to be here as my co-discussant, unfortunately, she was unable to make it. Um, but I get to co-discuss with somebody who I generally call a very close friend. I've gone the privilege of getting to know everyone in CP Solvers over time, but few have been part of this venture for as long as Kirtan, who is subbing into LMFT. I've known Kirtan since he was a medical student, and now he's a senior attending. Even though he just started, in my mind, he is certainly senior in full merit. But the truth is that Kirtan and I text much more often than colleagues or compatriots do. We now communicate on things more than just medicine, which is ironic because him and I probably don't only talk about two or three things about medicine anyway. But Kirtan, I'm so excited to share the stage with you, and maybe I can hand you the mic, and then we can introduce everybody else who's part of this.
Perfect. Thank you so much, Rabi. And I firstly wanted to thank our dear friend Elena. Like she has been very busy in the shift, so she cannot join on VMRs as often, and we miss her so much. And she gave me the opportunity to be here and discuss with Rabi. So I'm so happy. And just to make things more poetic, just the way Rabi did, I will just say one thing that often we say that in your life, some people come who create such a beautiful impact that you cannot imagine your life before them. So for me, the CP solvers and Rabi in particular has been that kind of impact that I don't know my past life, what was there before 2021, before I joined CP solvers, but all I know is that after joining CP solvers, the life is full of fragrance and light, right? So I'm so grateful that we have this beautiful community and I get a chance to discuss and learn from Rabi. And maybe now I can pass the mic to Kritika. Because of them, we are having this session. They are helping with the scribing and teaching points. So, Kritika, how are things going for you today?
Hello everyone. My day was good, Dr. Keith, and I hope everyone's having a good day. Very excited for the case today.
Perfect. Thank you. How about you, Jillian? I heard you did your step one prep today.
Hi, everyone. I'm excited to be here and to be scribing.
Thank you. And then lastly, we have Shiva who is joining us for the first time and presenting a case. We are so excited whenever someone else comes for the first time to present a case. We like feel very warm inside because we know that how difficult it is to take time out of the busy schedule, prepare a case, and then share what they learned with us. So we are very grateful, Shiva. And maybe we can ask you how are things going for you today?
So far, so good. Yeah.
Perfect. Thank you. Did you do anything fun over the Thanksgiving? Anything to take a
Uh,
break from?
Not
Mhm.
really. Actually, a Buffalo climate is not much kind to us. So yesterday we played cricket in the house. So yeah,
Oh, that sounds fun. But yeah, I could imagine that inside the house, maybe you don't have that much
yeah,
freedom and luxury, right? But I think
yeah,
it's okay. Yeah.
yeah.
You probably must know, are you a batsman, a bowler, all rounder, or what do you like to play?
All rounder, I would say.
Oh, of course you are. How could you not be? Oh my gosh. That's so cool. We're very, very excited for your case. Um, I think because I enjoyed hearing it so much, the YouTube audience to hear the full pronunciation of your name just once. And for anyone who can actually say it as well as you do, I think they deserve a special award.
Samba Sivarav Shringavarapu.
Oh, good. Amazing. I learned from Siba that it actually is a sub name or a category name of the god Shiva, and it is quote a more aggressive type of name. But as you're seeing, his smile does not match his name one bit. But maybe your case will have a aggressive tone to it, which we will hopefully catch and reflect on and understand. So whenever you're ready, you can jump right into your case,
Yeah, I'm ready. Should I start?
please.
Yeah, yeah. Okay. Th This is a 42-year-old female presented to the ED with progressive weakness, nausea, diarrhea, and inability to maintain intake of food or fluids since last 3 days. Her history of presenting illness, she has these GI symptoms since last 10 months, but last 3 days they were aggravated. And she reports intermittent dizziness, significant weight loss in the last 10 months. Review of system: no fevers, no hematemesis, no melena, no chest pain, no shortness of breath, no urinary symptoms, no skin rash, no joint complaints. I will stop here.
Amazing, Julian. You're ferociously scribing here. And Siva, maybe as you present the hourglass, just keep track of the scribe so she can keep up with you.
Oh, yeah,
Um,
yeah, sure.
yeah, no, it's all good. It's all good, my friend. I know, by the way, I know that when you're presenting for the first time, the nerves are through the roof. And so
Yes.
the voice tends to be through the roof. But one thing that can help you stay cool, calm, and relaxed is to try to keep your voice pace with the scribe, keep you relaxed a little bit.
Yeah,
Thank you for
sure.
this alquad. That's really, really interesting. Kirtan, what are you thinking?
Yes, so definitely striking aliquot because we know that this patient was having some illness which had a chronic flavor to it going on for 3 months, but now we know that things are taking turn for the worst and things are going downhill. So looks like that we had some GI centric symptoms going on for 3 months, but over the last 3 days, patient has been unable to keep any food intake. So as we always say that focus on the symptoms which you have in front of you right now and then try to link it with what has been going on for past 3 months. So if we just focus on the symptoms which we are having right now, what is something which is most worrisome and which stands out that you are unable to keep any food down? So is it implying that there is a structural defect somewhere in the GI tract, or is it a functional defect, right? The structural defect is something which we worry about more because you know that, let's say, if there is some kind of obstruction anywhere in the GI tract, or maybe some kind of, let's say, how to say, like volvulus is going on, or something is wrong with your GI tract that you cannot keep the food down, then that can be catastrophic. You might end up getting, let's say, perforation from obstruction, and which could kill the patient really, really fast. So you have to think about the worst possibilities that why this person is not able to keep up the functional intake, right? If it's not the any of the structural possibilities that we said, then we start thinking about the functional aspect of it. That is there something wrong with the metabolics of the body that they are not able to keep the food down, and that is why they are having nausea and vomiting. So you can think about all the different ways in which the food goes down your GI tract and how it can be impacted. So you can think about the motility aspects of the GI tract, and you can think about what are the factors which governs the motility of the GI tract, right? So that's what I would say for the acute complaint. Another aspect which makes sense is that how are you going to manage this patient, right? That you will check their vitals, make sure they're hemodynamically stable. You will give them fluids as needed. You will try to replete the electrolytes because for the 3 days, if they are having nausea, vomiting, and diarrhea, and they haven't been able to keep anything, you could imagine that their electrolytes could be in a state of disarray. And those electrolytes can be compounding the weakness and can cause more serious damage to other organs of the body as well. So getting the vitals, getting the labs, and trying to fix them as soon as possible is important. And then we can dig deep into the chronic history which has been going on, and that can shed light as to why this person has been having worsening symptoms. And given the young age of the patient, I would be worried that could there be any kind of, how to say, medication related adverse events which could be impacting this patient? Can this person have any relevant past medical history which might clue us towards focusing on the GI centric problems which we are having? So I think I'm taking it slowly. I'm trying to understand that what is going on right now. And then maybe as we get more data, we can try to zoom in. So Rabi, what do you think?
Yeah, I have nothing of substance to add, but just to reflect on your comment about the consequences of the GI volume loss. And I think just for emphasis for everybody, it goes to show you how our gastrointestinal tract is so key, not just to the quantity of volume in the blood, but also the composition. So Kirtan is entertaining both a reduced amount of plasma in the blood, causing dizziness and dehydration, but also open to perturbations in what the blood contains, low potassium, low bicarbs. And so it's just a re-emphasis of how crucial it is our intestines to keep the amount and the composition of everything in the blood. And I think that has to be the first aspect of stabilization of the patient. And Kirtan, I have to acknowledge that once you see so many patients, you realize that the specificity of nausea and the specificity of diarrhea to implicate true luminal gastrointestinal diseases. You know, so many patients I see who have nausea from chemotherapy or nausea from ACS or nausea from a migraine. And so many people who I see who have diarrhea don't actually have diarrhea. They have stool impact and incontinence. And even when they have diarrhea, they often have an extra intestinal reason like Legionella or hepatitis, so on and so forth. But gosh, I have to say the combination of the two, when you have nausea with diarrhea, that combination really implicates true luminal disease. So I would say that I'm proceeding forward with this case with two assumptions. The first is that even though nausea and diarrhea in of themselves are often not definitively suggestive of luminal disease, the combination certainly is a narrower DDL, and that all these extra intestinal symptoms, dizziness, weakness, so on and so forth, are likely complications rather than underlying clues. And these two things are very powerful assumptions because they help you move efficiently in the acute care of patients when you see so many of them. But it would be a mistake not to remind yourself that this is a helpful assumption to make, but it is an assumption that you are making that you have to make sure you can finally stamp with objective information as it comes. So let's see what Siva has correct option.
Yeah, that's a great discussion. One thing I want to emphasize is these symptoms are since last 10 months, not 3 months. And the patient has intermittent dizziness and significant weight loss in the last 10 months. Okay.
Very helpful, Siva. Maybe we can just incorporate our reflections on this additional data in the next talk. What do you think?
Yeah, sure. So it
Yeah.
looks like that. Rabi, you said you want me to discuss now or get the more
Oh no,
data?
maybe we can. Yeah, maybe we can get more data and then incorporate the data.
Okay, sounds good.
Perfect. All right, Siva,
Oh,
go ahead.
okay. Coming to request number 2, her past medical history. She has history of Hashimoto thyroiditis, mild asthma, and remote history of GBS, Guillain-Barré syndrome. And menstrual history, she is gravida 3, para 3. She has uncomplicated delivery an year ago. After delivery, she doesn't have lactation or resumption of menstrual cycle. But there is no postpartum hemorrhage history. She had an admission 9 months ago for nausea, vomiting, diarrhea. Was seen by GA at that time. Thought it. They attributed this to gastroenteritis due to post-infectious IBS. Later, they did colonoscopy and it came back negative. Coming to medical history, she is not on any meds, no significant family history, no significant social history, no allergies. Coming to examination, she is afebrile. Blood pressure is 110/70 with a heart rate of 105, respiratory rate 16, saturation 98%. And general appearance, she looks thin and she seems a little bit drowsy in the emergency department. HENT examination, normocephalic, atraumatic, dry oral mucosa but without any lesions. Eye examination normal. Cardiovascular examination seems a little bit sinus tachy. Regular hearts S1, S2, no murmurs. Uh, Peripheral pulses intact and her capillary refill is less than 2 seconds. No pedal edema. Respiratory system was normal. Gastrointestinal system, abdomen is soft, non-tender, non-distended. Bowel sounds present throughout. And musculoskeletal system normal. Neurological system, she's drowsy, alert to voice. She's oriented to person, place. Sensations intact. Power 5/5 all limbs. I'll stop here.
Your pace is perfect. Thank you so much. I really, really appreciate it. All right, Dr. Pakolia, let's unleash your clinical wisdom, my friend.
Perfect. Thank you. So if we try to frame the problem which we have so far, we are dealing with a young lady who is presenting with chronic GI symptoms complicated by acute worsening. And we, as Rabih emphasized, that we have combination of both, which is very unique, that we have nausea, vomiting with diarrhea. And from the examination, we can say that this is significant because patient has tachycardia, although blood pressure seems okay as of now, but definitely patient is trying to compensate for it, right? And patient has dry mucous membrane, patient looks thin, and we got from the history that patient has lost significant weight as well. So one thing we know for sure that this GI illness is not something which has been trivial, because oftentimes what happens that people will say that they have been having diarrhea for last 5 months, but when you really clarify, you will find out that maybe they are having like one loose stools every day and they haven't lost any weight, their protein is looking fine, their physique is looking okay. Then you start wondering that how significant is this diarrhea, right? But in someone like our case, we have a consistent history and we are seeing the implications on the patient's like physical appearance, then we know that it is significant, right? So that helps put things into perspective. And then if we try to link it to the past medical history which we got, that looks like that unfortunately after the childbirth, this patient was not able to resume the normal menstrual cycles, was not able to lactate as well. So how we put that into perspective? Before I integrate that, one important point which I wanted to raise was that in the first half, we discussed that how nausea, vomiting, and diarrhea can stem from a functional issue or can stem from a structural issue, right? So you could imagine that can this person still have a structural issue? Definitely. There could be some obstruction somewhere in the GI tract, something which is anatomically causing this. But if it has been going on for 10 months, then the likelihood of it starts to go down and you start wondering about the functional implications. So if you just think about it, that how can you end up getting diarrhea, or like, so you will end up getting diarrhea if there is something wrong with the mucosa of your GI tract, something wrong with the way you absorb the nutrients which you are taking, and something which implicates the secretory nature of your mucosal lining. So there are so many humoral factors which can lead to leakiness of your mucosa and you can end up causing diarrhea. And then there are so many hormonal substances in our body which governs the motility of the GI tract and which can cause nausea, vomiting, and diarrhea. So if you think about it, if someone has, let's say, thyroid dysfunction, if their thyroid is excessive in the amounts, it could cause so much GI motility that you will end up getting secretory diarrhea and you can also get nausea and vomiting. And once you have one endocrinopathy, just like how autoimmune diseases travel in pairs, endocrinopathy often also travels in pairs because the underlying autoimmunity, which is predisposing you to, let's say, thyroid dysfunction, can also predispose you to other endocrine dysfunction, like let's say diabetes mellitus or let's say adrenal dysfunction, right? So in a young person who already has a thyroiditis going on, you start wondering that along with thyroid, should I check for other hormonal axis as well? And is it compatible with our clinical picture? So having that perspective in mind, keeping her background in at the back of our mind, if we start thinking that, is this story compatible with adrenal insufficiency? So we know that how adrenal gland produces various hormones, including like cortisol, aldosterone, and variety of sex hormones, and how they govern different parts of the metabolism in our body. So cortisol plays a very crucial role in GI motility as well, and as such, the electrolyte composition as well, along with aldosterone, right? So when your cortisol levels are low for a long period of time, you could end up getting cachexia, you could end up getting weight loss, you can have protein wasting as well. So in this person who has been having like weight loss for a long time along with GI symptoms, it is a hypothesis which we might entertain. And even more so because after the childbirth, let's say if you are not able to do the lactation, then what does it mean? It means that maybe you do not have enough prolactin in your circulation. And you start wondering that how can your prolactin levels be low? So you know that prolactin is released by the pituitary. So you immediately start wondering that can something have happened immediately after the pregnancy which compromised the ability of pituitary to release the prolactin? And since pituitary is such a tightly knit structure that if you are affected, it's kind of like your brainstem, you know, that like if you have one cranial nerve involved, it is likely that you will have other cranial nerve involved as well, right? So if your one hormone is impacted, it is possible that maybe other hormone is also impacted. So I'm trying to think that in my mind that why this patient is not menstruating, like are the gonadotropic hormones also implicated? And along the same line of thinking, is it possible that maybe around the same time the adrenal axis was also implicated? So I'm going to go deep into that route to do a thorough hormonal evaluation and then try to see if I can make progress from that And maybe I can ask Rabih that what other domains we should consider.
Yeah, Kirtan, like I said earlier, I think I'm discussing with a colleague, not somebody who can add and talk to. I think it's amazing the conclusions you're coming to. And so the only thing that you and I can continue to offer the audience is just to show people how different people think in different ways, ultimately coming to the exact same conclusion. And the way, Kirtan, my mind is set up now is it interesting. I'm having an internal debate. I'm asking myself, what do I care more about? 50 pounds of weight loss or the gastrointestinal symptoms? And I'm saying that out loud because I find that let me see who is unmuted. Okay. Yeah, I think it's an interesting thing to ask yourself. Do you solve GI and then incorporate weight loss? Or do you solve weight loss and use GI as a flu? And I think that 50-pound weight loss dwarfs the GI symptom. And I say that because we started our analysis by outlining the assumptions we made. Right? Hey, we think this disease lives in the lumen because of the combination of the nerve and diarrhea. And we think that everything else, dizziness, weakness, is a consequence of the GI tract's loss of function to maintain homeostasis. But when you lose 50 pounds of weight, that assumption has to break. You cannot lose 50 pounds of liquid from your GI tract. So there must be some solid weight loss. So for me now, I am looking for a systemic disease consuming the patient. And the clue that I am using is gastrointestinal dysfunction. And I find that to be a very unique problem to have because weight loss from GI disease is unfortunately one of the most sneaky causes of weight loss. Gastrointestinal, upper and gastrointestinal cancers, esophageal cancer, stomach cancers commonly do so. But what we have here is the very unique setup of the entire lumen, from upper with the nausea and lower with diarrhea, dysfunctional. So as I start to think about what kind of process can consume the whole body and affect both the stomach and the colon at the same time, and I'm trying to imagine, could it even remotely possibly be a disease that shows up on imaging? And I think the answer is imaging of the GI tract. The answer has to be no. Can you imagine a disease that takes over the entire gastrointestinal tract and yet doesn't seem to cause symptoms in the chest, doesn't seem to cause symptoms in the legs? It seems so devastatingly destructive to the GI tract. And so that's where I immediately start looking for a substance. What molecule is consuming this patient's body because it seems to be affecting every single cell in their lumen? And that is a very, very, very powerful conclusion to come to because most of the time, when you look up a patient with weight loss, you don't find a substance, you find a structure, an imaging modality, a large mass here, a large abscess here. But if you are in the world of weight loss and you are on the hunt for a substance, even in the absence of the patient's endocrine clues in their history, you should be suspicious of an endocrinopathy. So my argument to you all is that the tools we can use for clinical reasoning are very, very powerful. And I would argue that even in the absence of this patient's rich endocrine history, both the thyroid disease and the failure of lactation after pregnancy are elevate the hypothesis, but I think you can arrive at this hypothesis of a substance-mediated cause by realizing that weight loss is often a systemic radiographic disease. Imaging proves the answer to weight loss in the majority of people. But entire gastrointestinal dysfunction, from mouth all the way to colon, plus a structural disease is very, very hard to do. Almost always a substance. So now what am I doing? Substance-induced weight loss. That's my priority. And that's when I look in the medical history, and I'm like, oh my God, everything Kirtan is saying about the possibility of hypothyroidism, possibility of adrenal insufficiency and VMRs, also open to an exogenous substance that is doing this as well. So nothing to add to you, Kirtan. I'm just showcasing how uh, people like me and you who are obsessed with clinical reasoning, even though we're essentially training in parallel, our minds consume the data very, very differently, but I'm coming to the same conclusion you are. And I'm really, really eager to see what the remains of the data. Thank you,
That,
Simon.
that's a great discussion. I'll go to the next aliquot. Here, her CBC hemoglobin is 10, WBC is 4K with the normal differentials, platelet is 300K. Coming to chemistry, her sodium is 133, potassium 4.3, chloride 101, bicarb 21, calcium 8.8. BUN and creatinine are normal, and blood glucose is 30. AST, ALT, bilirubin, albumin was normal, and they have done a USG abdomen pelvis which came back normal. I'll stop here.
God, this is an unbelievable case. So, so well presented. Thank you so much. All right, Dr. Patel, what are you thinking?
Perfect. So, friends, as Rabi kind of summarized very well for us in the end of the last report, that we are trying to focus on a physiological slash substance induced GI predominant symptoms characterized by weight loss as the prominent symptom, and then you are thinking about nausea, vomiting, diarrhea. We got the examination which was suggestive of dehydration, suggestive of like volume depletion. Patient's physique was looking as if they have lost lots of weight. And we got the labs which suggested that very profound, actually, severe hypoglycemia. If it's, I think Siva said it's 30, so I presume it's very low, right? And then electrolytes looked okay, like sodium, potassium are fairly fine. So first things, as we said in the first episode, right, that let's focus on management, that something could be really, really wrong and you don't want to wait for the diagnostic process before you make progress in the management aspect, right? So let's fix this person's sugar right away. And from what we have learned from our recent rapid fires with Rabi, that if possible, give them IV dextrose. That is the best way because patient is a little bit drowsy. We don't know how much they can take by mouth. You can offer them something to eat to bring their sugar up right away, but it's better to just give IV dextrose. That is the ideal way to raise the sugar levels safely and fast enough, right? Having done that, then we start figuring out that I'm thinking of a molecule which could do all of this. Am I missing any other pieces of the puzzle? That apart from a molecule, can there be anything else wrong with the blood which could be messing up this person's body, right? So for a moment, you ask yourself that, can this be a toxin-mediated cause? We know that so many toxins, just like endocrine hormones, can affect so many parts of the body without leaving a trace anywhere on imaging. But a toxin which is causing symptoms for 10 months and has still not affected other parts of your body might be a little bit too much, right? If this was an acute case, then you could think about any multitude of toxins derived from food, from medications, which can cause nausea, vomiting, diarrhea. But for 10 months, the likelihood of the toxins starts to go down. So I wanted to raise that point, that's why that hypothesis is less likely. Then second, another important bucket we have to consider is that, can this person have some autoimmune disease apart from the endocrine effects? The reason why I bring this up, that often in medicine, what happens is that we sometimes anchor on one concept, and it's okay to anchor on one concept. That's like type 1 thinking. But you also want to take a step back and make sure you are taking a bigger picture, that it's a young lady. What happens in young people, and especially if they are like females, it's some autoimmune diseases. So you want to consider that as well. Is it possible that this person can have, let's say, lupus, which can be affecting different endocrine organs, which can be affecting the GI tract as well? And we have learned from the prior cases on CP solvers that how lupus can present in atypical forms in certain population, and it may not present with the classic symptoms. So lupus is one of the autoimmune diseases which you want to consider in a young person when they have so many organ systems getting involved one by one, and you don't want to miss that cause, right? So I'm thinking that if I'm thinking of lupus, what else I should find on examination? So I will make sure that I do a thorough examination, look at their hair, look at their oral cavities, look at their eyes, look at their joints, skin, any other evidence of lupus-related end organ damage, right? Having said that, is there anything else in the blood which can do it? There are certain neoplastic disorders which can present with nausea, vomiting, diarrhea, all these symptoms. And we know that sometimes the endocrine dysfunction can stem from a cancer somewhere in the body, usually a small cancer, which is affecting the endocrine axis by releasing certain molecules, forming certain antibodies. But given the age of the patient, maybe you will be inclined to think that if there was a cancer sitting in the body causing all of this for 8 or 10 months, it would be implicated by now on imaging, and you might find some any other end organ damage, which we are not seeing. So that hypothesis also goes down. So before diving deep into the adrenal axis, this is what I wanted to lay down, that what other things are at the table, like toxins, certain autoimmune diseases, neoplastic disorders, and we wanted to exhaust all of them. And now coming back to our original hypothesis that looks like this person can have pituitary dysfunction affecting all the axes, including the GnRH axis, ACTH axis, and maybe that's why this person has been having nausea, vomiting, diarrhea, and weight loss. Often in med school, we are taught that if you see a person with adrenal insufficiency, you should expect they have hyponatremia, hyperkalemia, shock, and hypoglycemia. So I wanted to bring up this point regarding potassium, and it has happened multiple times when I was in residency that we would raise the suspicion of a person having adrenal insufficiency, and someone will say that, well, patient's potassium is fine. How can they have adrenal insufficiency, right? But here is the counter argument that imagine this person has been having nausea, vomiting, poor oral intake, and diarrhea for 3 days, and maybe even more, their intake has not been good, right? So that would deplete the potassium. So although adrenal insufficiency will push up the potassium, but the consequences of adrenal insufficiency on your GI tract are depleting the potassium. So in the end, things can counterbalance, and maybe your potassium levels are normal. So you cannot lay your you cannot lay your suspicion just on the potassium levels to decide if this person has adrenal insufficiency or not, right? And what about the sugar levels? That is one of the more striking examples of how adrenal insufficiency can cause so much havoc in the body without affecting the potassium levels. So in this case, I will be even more concerned about adrenal insufficiency now that we have evidence of hypoglycemia, and we know that how cortisol hormones plays a crucial role in gluconeogenesis in the body. So fasting hypoglycemia is one of the consequences of adrenal insufficiency. So that is where my mind is at right now, that we need to find out the hormonal derangements going on in this person as soon as possible before there are more hemodynamic derangements going. What do you think, Rabih?
As always, right there with you, my friend. My reflections here will be brief, because I'm coming to the same conclusion you are, but just would make the argument about what I would do next steps in the emergency room. And so there are many ways to test for adrenal insufficiency. I will tell you that in the inpatient setting, the test that we often do in the outpatient setting, i.e. an AM cortisol, is noisy because the patient is sick, often hypoalbuminemic, and so that test is actually not a very wise thing to do in my opinion. I would recommend that we immediately jump to a concentration stimulation test. So as I've had the chance to do maybe once every year or every 2 years in my emergency room, immediately upon receiving this data, I would order an ACTH stimulation test. But what that does is it gets a baseline cortisol, and then you inject 250 micrograms of ACTH, and 1 hour later, we can diagnose adrenal insufficiency. This is something that anyone can do anytime if you have an IV. You do not need to wait for anything. You don't need to wait for 8 a.m. the next day. You should do this right now. And I say this because even though adrenal insufficiency is an uncommon condition, it is deadly. And so we have to think about many things if the ACTH stimulation test is negative, but I think you really, really have to do it. And some people would be so worried about doing adrenal insufficiency, they might empirically treat the patient. If you are going to empirically treat the patient, my advice is to give them dexamethasone because it is the one form of adrenal replacements that does not affect the testing that we need to do. So adrenal insufficiency is a rare esoteric diagnosis, but it is deadly. So if the moment you think of it, realize that the testing that you've been taught is very time dependent and complicated, but in the inpatient setting in a patient with IV, you can diagnose this condition extremely fast. In fact, I don't know of a condition that you can diagnose as fast as adrenal insufficiency because all blood work requires an hour, hour and a half to come back. And what you need to do for adrenal insufficiency is to inject 250 micrograms of ACTH, and 1 hour later measure the cortisol. And there's your diagnosis. I also just emphasize briefly that everything that Kirtan said is 100% true about the electrolyte abnormalities in adrenal insufficiency. And let me give you some number. So 95% of patients with adrenal insufficiency have hyponatremia. 95. Only half have hyperkalemia. Only 20 to 30% have hypoglycemia. So that's just the big picture. Now, if you zoom in on why, if the patient is suspected to have primary adrenal insufficiency or disease at the adrenal gland itself, the rate of hyperkalemia goes up to 80% because in the primary adrenal insufficiency, there's hypoaldosteronism. If the patient is suspected to have secondary adrenal insufficiency from pituitary dysfunction, the rate of hypokalemia is actually measurably low because aldosterone is there to get rid of all the excess potassium from the thyroid glands. The exact opposite is true for hypoglycemia. In primary adrenal insufficiency, the counter-regulatory hormones of the thyroid axis, growth hormone, usually keeps glucose levels maintained. However, when you have secondary adrenal insufficiency, along with other pituitary hormones that also contribute to glucose homeostasis, such as growth hormone and thyroid hormone, the risk of hypoglycemia increases. So to teach it quickly, hyperkalemia, primary adrenal insufficiency, hypoglycemia, secondary adrenal insufficiency from pituitary disease. And so when you average it all comers, the only thing that's reliable is hypernatremia. Everything else is subject to noise, but also localizations. So in this case, Kirtan, with the history that you latched onto, the case for secondary adrenal insufficiency from pituitary disease is screaming so large, I can't even stop wearing my ear hats without moving past it. And it also might explain why the patient does not have hyperpigmentation on exam, because ACTH excess is required for that feature. So if we are wrong and this is not adrenal insufficiency, I will not regret spending so much time talking about it because it's exactly what I think we should do in the emergency room, is rule it in or rule it out. Either way, you have a good test that can tell you yes or no. All right, so I'd like to.
That's a brilliant discussion. Thank you. Okay, coming to her next labs, her TSH is 2.9, which is normal. Free T4 is 0.47. The reference range is 0.8 to 1.8. And her prolactin is 1.6. Normal is 3 to 30 nanogram per ml. And our LH is 1.3, FSH is 6.1. Both are in normal range. LH is 1.3 and FSH is 6.1. Both are in normal range. And morning serum cortisol is 0.5, which is low. ACTH is less than 5, low. Dehydroepiandrosterone sulfate is 3, which is low. And her 21 hydroxylase antibody came back negative. I will stop here, and I have one more aliquot which will reveal the diagnosis.
I can't believe this is your first presentation. Really, really impressive. Thank you so much. All right, Dr. Pagolia, this is all for you until the end. I will now be forever brief.
Perfect. So, as Rabih explained very elegantly in the last report, right, that given the history which is implicating the pituitary to be involved, and now we have the evidence that all the hormones are low, even the stimulating hormones are low, like the ACTH, LH, FSH. So you know that it's not going to be the primary insufficiency, because if it was primary, then you would expect ACTH levels to go high or at least inappropriately normal, right? And also the fact that patients' dehydroepiandrosterone sulfate is also on the lower side. We know that ACTH controls the sex steroids as well, and DHEAS is one of the specific sex steroids which is released from the adrenal glands. So all of this points to the pituitary dysfunction. And you ask yourself that how can this happen? That what is the physiological basis which I have? So Shiva specifically told us that this patient didn't have any postpartum hemorrhage, because in our mind, we often think that it's because of the postpartum hemorrhage and ischemia to the anterior aspect of the pituitary gland that you get hypopituitarism. But to be honest, if you look at the data, you will find out that most of the people who have Sihan syndrome didn't have overt shock or didn't have overt postpartum hemorrhage. And often it's difficult to quantify how much bleeding happens during the delivery because so much blood can be still sequestered inside the gynecologic tract. And eventually it will come out, but it is not inside your circulation. And often during pregnancy, the pituitary enlarges. So the blood supply doesn't enlarge as much as in proportion to the size of pituitary. So there is always supply demand mismatch going on at the level of pituitary. And all you need is at the end of this like 9-month journey when the baby is about to be born, any minor derangement in the hemodynamics, even if it is not evident on your screen in terms of blood pressure or heart rate, can end up causing ischemia to the pituitary. And that is how you get this pan-hypopituitarism affecting all the hormonal axis. One notable aspect is that often the posterior pituitary has more robust blood supply, almost like so many collaterals are there, dual blood supply. So whenever you have hypopituitarism implicated in the postpartum setting, the levels of ADH hormone are usually intact. So it kind of tells you that why the prevalence of diabetes insipidus as such following the postpartum hemorrhagic event is less compared to all other hormones which we talked about. So physiologically speaking, we have good evidence of why this person might have this. And then if you think about the data which Shiva told us that the 21 hydroxylase antibody was negative. So what Rabih was telling us in the past aliquot that the most common form of adrenal insufficiency in general in young people is the primary adrenal insufficiency, which is a form of autoimmune adrenalitis that you form the antibodies against different components of the adrenal glands, one of which is the 21 hydroxylase enzyme. And that's how you get autoimmune adrenalitis. So the fact that in our case, even that was negative, although we suspected it from above itself that it's not going to be primary insufficiency, but this is another kind of final nail in the coffin kind of stuff that this is not looking like primary insufficiency. It is more of a secondary insufficiency. Another important point which I wanted to mention was that patient's TSS T4 was normal. So the thyroid and adrenals, they are always intertwined with each other. So if you think about the management of people who are in thyroid storm or people who have hypothyroidism, you will often see that the guidelines suggest that you might give steroids to people who have thyroid storm as well. The reason is simple that if there is too much thyroid hormones in the body, it will catabolize everything else, including the cortisol itself. So even though you may not have adrenal insufficiency, you will have subclinical adrenal insufficiency in people with thyroid storm. And that's why you give both of them. And same applies actually to adrenal insufficiency as well. That often in people with adrenal insufficiency, the reason why they might be very hemodynamically tenuous is because they have simultaneous thyroid failure as well. And we know that thyroid hormone also plays a crucial role in maintaining the chronotropy of heart, in maintaining the vascular competence, right? So I am glad that Shiva's team did a thorough workup and they looked at the TSS T4 as well, because it is perfectly feasible that this person can have concurrent secondary hypothyroidism as well. And just fixing the adrenal axis may not completely cure the patient, right? So but in our case, since it was normal, we can say with confidence that now I have identified the problem, localized it to the primary pituitary failure related adrenal insufficiency. And what we need to do now is give the stress dose steroids. So maybe I can lean on Rabih to figure out that what's the ideal dosing which Rabih utilizes in the ED setting.
They're absolutely superb. I think I might have missed it, but I thought the TSH was normal, but the free T4 was low.
Yep, that's right.
Yeah.
Oh,
So
thank you so much.
yeah, yeah, it was slightly low. So what do you think about how does that change your analysis?
Yeah, that's a little bit tricky because in general, what happens is that we rely on TSH more to make assumptions about how the thyroid axis is working, but that assumption fails when you have primary pituitary disease because you cannot rely on TSH levels and you rely more on the T4 levels. So thank you for highlighting that, Rabi. I didn't catch that it was actually low. So the fact that it is low, then back to our initial hypothesis that, well, you should supplement thyroid together as well, give levothyroxine as per the dose based weighting, and let's see how it goes.
Yeah, I completely agree with you. I think the diagnosis probably here is panhypopituitarism, because you might ask yourself, what do you expect FSH and LH to be in terms of normal or not normal? And I think it depends on where in the ovulatory cycle the patient is, and that's hard to determine when there has been. Well, actually, I probably transpose failure of lactation to failure of menses. I actually forget what the patient's menstrual history is, but the timing of the receipt of SH and LH in the testing was really key. But the probability of panhypopit, anterior panhypopit, has been so well articulated by Kirtan. So, yeah, in terms of the treatment, I don't know the details of how corticosteroid replacement is done in terms of the specific dose, but I think there's a key point to emphasize, which is that in primary adrenal insufficiency, you have two hormones to replace. You have cortisol and aldosterone. And so you need to use steroids with both steroid activity and mineralocorticoid activity, like hydrocortisone. However, the aldosterone excess is maintained in patients with secondary adrenal insufficiency. So you do not need mineralocorticoid replacement. So something like fludrocortisone or hydrocortisone is less useful in these patients. So often, what I've seen is medications like dexamethasone or medications like prednisone are used in this. Any comments or reflection on that, Kirtan, before we learn from Siva?
No, that's perfect. Thank you for highlighting that how two hormones play an important role and when to replete in what setting. So excited to learn from Shiva.
One thing
I
I
have,
just, yeah,
yeah.
go ahead, Siva. Sorry. I was just going to ask Kirtan if he has any wisdom for us about what the MRI findings might reveal in a situation like this if Siva were to obtain it.
Yeah, I do have two
Yes.
MRI images I can
Yeah,
share. That's okay.
go,
Yeah.
go for it. So while Siva is pulling it up, Kirtan, what do you think the MRI will show based on your
Yes.
knowledge?
Yes, so if it is really what we suspected, that postpartum hemorrhage, then I should expect that there might be atrophy of that part of the pituitary gland, and that would reflect in something known as like empty sella, which means that the sella turcica in which the pituitary sits might be relatively empty, and you might see a void in that region. So that is what I'm expecting, and let's see this image now we have. Yeah, looks like that the part where Sella turcica is, you can see that it's black. So there is air or fluid there, but not the substance of pituitary, how it should be. That is what it looks like to me, Rabi. How does it look like to you?
And I have one more sagittal view.
Yeah.
My favorite part of this image, Kirtan, is that it says case 1 CPS, which hopefully means that there will be case 2 CPS. So that's not only
Yeah, hopefully.
Yes.
Okay, I'm gonna read the MRI. 1 second. So the radiologist reading is findings compatible with 3 microadenoma, right lateral pituitary gland. Pre-contrast T1 hypertensity may reflect intralesional hemorrhage.
Perfect. So looks like that we are seeing a adenoma and some hemorrhage. Now, often in pituitary world, we have to be very cautious when we see any imaging findings because we know that at baseline, the chances of someone having pituitary adenoma, which is incidentally found and has no impact on the hormonal axis, is very common. So in general, the most common kind of adenomas which we see in pituitary region, either they only release prolactin, so they are prolactinomas, or they are so tiny that they don't release anything at all. So they are hormonally non-functional. And if pituitary tumor is really, really big, then sometimes it can happen that maybe it will outrun its blood supply and you will have the hemorrhage inside the pituitary tumor itself, something which we call as like the pituitary apoplexy, and which can present with like dramatic consequences like acute onset hemodynamic collapse, headaches, visual changes. In our case, we didn't hear the story about patient having any kind of headaches or any severe head and neck symptoms, but sometimes things can be atypical. So you have to be open to the possibility that it might be feasible that this tumor was real and maybe it underwent hemorrhage inside it. But maybe I will ask Rabi more that what's his consensus on like this tumor and some hemorrhagic products.
Kirtan, I think I cannot articulate it better than you. I will just tell you that the finding of central adrenal insufficiency really restricts the range of probabilities of pituitary disease. The reason for that is that the ACTH producing cells in the adrenal glands are very tightly maintained. And so it is a clue that if you have pituitary disease, adrenal insufficiency from pituitary disease, that you are either suffering a vascular phenomenon or a targeted attack by medications like immunotherapy or autoimmune diseases like autoimmune fasciitis. So when you have, there are many things that cause pituitary disease, but if you have central adrenal insufficiency, vascular, meds, and immune are big, big culprits. And so I think that within vascular, the unifying theme is hemorrhagic necrosis. That's essentially what happens. And the hemorrhagic necrosis uh, comes in two flavors. The first is there is a pre-existing tumor in the pituitary that outstrips its blood supply, called pituitary apoplexy. The second is that the enlargement of the pituitary is not from a tumor, but from physiological enlargement of pregnancy, and then it has hemorrhagic infarction as a result of a blood loss in pregnancy. And so I don't see a reason why these two things are not synergistic and additive in this patient. And I say that because the rate of spontaneous tumor-induced bleeding is related to the tumor size, and 3 millimeters is on the smaller side. So if I had to make an educated guess at what happened is I think the patient has features of both diseases, where she has an adenoma, and she was pregnant. I don't think it's a coincidence that her pituitary failed after pregnancy, but I also don't think it's a coincidence that she has a 3 millimeter adenoma. In other words, what we know for sure is her pituitary failed after pregnancy. So the contribution of Sheehan or Sheehan-like physiology is very implicated based on timing. But if you ask me, who's at higher risk of developing Sheehan or Sheehan-like physiology, a patient with or without a 3 millimeter adenoma? And I would say a patient with a 3 millimeter adenoma. More and more tissue, more and more growth, more and more vulnerability to ischemia. That's my educated guess. I'm curious how that hypothesis meets with your analysis, Kirtan.
So no, Rabi, I agree with you that if it was just a tumor-driven process, then maybe we would expect the tumor to be bigger and the consequences to be more profound. But maybe what happened was that it's the pituitary which was vulnerable, and adenoma kind of ended up becoming a bystander. And the hemorrhage which we are seeing, again, we are not sure if the hemorrhage is purely within the tumor itself, or is it in the whole pituitary? Because if it is in the whole pituitary, then the hypothesis which you said and which we suspected, that we don't think that this patient had adenoma which had hemorrhage in it 9 months ago, right? This patient has been having symptoms for so long. So we know that the adenoma cannot be implicated in the symptoms which started 9 months ago. Maybe that was the pituitary failure from the Sheehan physiology to begin with. And now adenoma just, you are seeing it incidentally, or maybe as Rabih said, that it increased your vulnerability. So yeah, that's my sense as well. So excited to see what Shiva has in store for us.
Yeah, you guys are really right on the track. The team has diagnosed the neurosurgery team has diagnosed it as Sheehan syndrome. Because one theory is the adenoma might be present previously and it is vulnerable. That is one theory. And the other theory is sometimes usually in Sheehan syndrome we expect patchy necrosis, like the pituitary should be gone. But they said like in this case it can be due to proteinaceous rich necrotic fluid. It can look like a microadenoma in radiology. So that might be a possibility. That's so the diagnosis was Sheehan syndrome.
That's a very enlightening explanation, Shiva, that maybe what we think is adenoma is not
Yeah.
adenoma to begin with.
Yep. So,
That's so cool. Yes.
yeah, I was not involved in the patient care. I have never met, but I got this case through a resident, so she taught me all these things.
Right. Say thanks to her. Because of her, we are learning so much
Yeah,
today.
yeah,
Yeah.
yeah, sure, definitely.
Yeah.
I have to say thanks to all of you, Siva. This was such an incredible case, and it, the fact that you didn't even meet the patient elevates it in two really special ways for me. The first is you still presented it so clearly as if you knew the patient inside out, and the second is that um, desire to learn and grow and to bring a case that you didn't see is really special to see. So thank you very much. Thank you also for streamlining your presentation so Jillian could keep up with the ferocious amount of data you had. And then a
Uh,
huge thank you to Kirtan. I really enjoyed. I can't believe that you're a first year attending. I was having some flashbacks as to when I was beginning my journey in clinical reasoning as a first year attending, and I must authentically say, I think you are. I drive a Subaru, a very old a Subaru. You, my friend, are a Ferrari, and it's leaving everything in the dust. I hope you like Ferraris. I don't like Ferraris. I don't know why I use them.
I mean, I don't
But
even know how to
speaking,
drive
yeah,
car. Ravi, I don't even know how to drive car. I just walk.
it's probably better for the environment, my friend. Unfortunately, uh, I have to head to my car because I'm a little late. So maybe Kirtan, I can make you the host, and I will be very excited to check out Kritika's excellent teaching at the end.
Awesome. All right. Thank you, Shiva, once again. And Kritika, you can take us home.
Thank you so much.
Thank you for such a beautiful case, Shiva. It was very interesting. So coming to the teaching point, so we had a 42-year-old female who had weakness, nausea, diarrhea. So Dr. Kirtan mentioned that there could be a structural or a functional defect. So when we take these complaints, and we always need to look for emergencies like perforation firstly. And apart from that, Rabi also mentioned that if nausea, vomiting, or diarrhea is present by itself, generally we can't localize it. It could be even a general systemic cause. But when they are present in a combination, you can probably put it as a luminal cause. And here, this patient was a young female, so which makes the possibility of a autoimmune etiology very likely. And provided she also had history of Hashimoto's, we were thinking of a multiple endocrine cause like adrenal, thyroid, and diabetes. And she also had lactation problems postpartum, so that also fits into the endocrine bracket. And generally, when we think of weight loss, we think of a gastrointestinal cause, which can be localized based on radiographic imaging. But Rabi very beautifully mentioned that because there is diffuse GI involvement here with nausea, vomiting, and diarrhea, we can mostly think of a substance like a endocrine cause or a toxin. But toxin doesn't fit here because of the time period. And the other differentials that Dr. Keaton mentioned were toxins, any autoimmune like lupus, which could present with multiple features, and any neoplastic or paraneoplastic etiology. But then the one which fixed on was adrenal insufficiency because patient had hypoglycemia. And the other factors that we look for are hyponatremia, hyperkalemia, and shock. And Dr. Akita mentioned that hyperkalemia is not a hard and fast feature that you need to look for. And one very important thing that we need to see is that hyperkalemia is more likely in primary more than in secondary adrenal insufficiency, while hypoglycemia is more common in secondary than in primary adrenal insufficiency. And in this case, the most interesting feature was for us to differentiate between Sheehan's and pituitary apoplexy because we had a tumor. And Rabi beautifully mentioned that the presence of the microadenoma probably makes the possibility of Sheehan's more likely. And we also ended with a beautiful point that the adenoma might not be even a true adenoma. It is possibly just a pseudoadenoma. Thank you.
Perfect, Kritika. So well articulated, and you highlighted all the key points, including the final point, which was a new learning for all of us, right? That how the proteinaceous contents subsequent to the necrosis can mimic the adenoma. So thank you so much for highlighting that. Thank you again, Shiva, for helping us and sharing the case with us. Thank you to Jillian for scribing, and thank you to everyone for joining. See you next time, friends. Take
Thank you so
care.
much.